So one case, and as Dr. Matthew said, it's easier to say case. I'm one of the fellows at BC Children's Hospital. I'm in my second year of fellowship. I'm to speak a bit about liver biopsies in clinical practice. I'm going to present a little about the preliminary data I have about studying something about liver biopsies for 6-7 years. Data on what we found about the different demographics and complications in liver biopsy experience at BC Children's Hospital. Can you guys hear me at the...
Not easily.
Okay, sorry, okay. So the objectives of today's talk would be, I would be speaking about the history of liver biopsies, the types of liver biopsies, the indications and contraindications, along with, I will be discussing about biopsies and selected diseases, and the complications which you would expect with a liver biopsy, what type of biopsy you would select for which patient, and a bit about the research, what I've been going on at BC Children's Hospital. So, why do we do a liver biopsy per se? It's to get simply the diagnosis of liver diseases, to look for how to manage and stage liver diseases, what you will see in chronic hepatitis. I'll be speaking about that in detail later on. The liver in itself reflects metabolic diseases which are going on in your body, and the easiest method to obtain liver tissue is a liver biopsy, and the protein is over transjugular, right? So, when was the first liver biopsy performed? The first liver biopsy was done in Germany in 1880 by Paul Ulrich. He did this so that he wanted to prove that there's glycogen deposition in the liver during dialysis. That's the reason he did the first biopsies. He proved that there's glycogen deposition in the liver. Though prior to that, in 1825 and 1833, there have been reports by Stanley and Rickamer from London and Paris of liver puncture being done for echinococcus infections so as to drain the cysts. And subsequent to that, the timeline shows that in 1895 there have been liver aspirations to see cytology for renal malignancies. And however, the first core biopsies which histologists found that would be useful to have a look at tissue was done somewhere in 1907 by Stupfer in Germany again. And from 1926 to 28, there have been a series of case reports going on to prove that liver biopsy is safe, is helpful in diagnosis of diseases. But it was still not accepted as a standard procedure and a practice to do liver biopsies to diagnose diseases still. The second stage of liver biopsies did come up somewhere in 1939 to 1958. In 1939, we had, I don't know, some of the old timers might remember it. This was a Wim Silverman needle which was introduced in 1939 by Silverman. And this is basically a cut-in type of needle which goes in and takes a small core of tissue which is helpful for biopsies. And however, liver biopsy was accepted as a standard practice somewhere in 1958 after Mendel introduced what he called the 1-second biopsy needle. 1-second biopsy needle is essentially a needle which shortens the intrahepatic phase of liver puncture to less than a split second. Hence, the complications are said to be pretty less in terms of a liver laceration. Because the person is told to hold breath during the liver biopsy so that the liver doesn't move and you don't have lacerations of the liver. And this reduces the intrahepatic phase to less than a second. So the complications are pretty much less. Now, the third stage did come in terms of image-guided liver biopsies. The reports started coming somewhere from 1960 onwards. The first aspiration of a liver abscess was described in Shanghai by Wan Sing Fang. However, he didn't do a liver biopsy. This was just an aspiration of a liver abscess, ultrasound-guided. The first ultrasound-guided liver biopsy, which was suggested as a method of reducing complications and image-guided, was done somewhere in 1983, where it was recommended as a standard of practice. And there have been various reports going on in terms of in 1967, the first transjugular, in 1979, Raga et al. Had CT-guided biopsies, and in 1988, we had what's a transfemoral biopsy. So the transfemoral biopsy is supposed to be as efficient as a transjugular biopsy of the liver tissue, and a transfemoral liver biopsy has an equivalent success rate with lesser number of complications, though it's not routine in practice. Now, what's the current state of affairs? Liver biopsy is an invasive procedure. Parents would think twice before putting their kid through a biopsy. And when you have chronic diseases like HCV or autoimmune hepatitis, you will keep wanting to follow up how the liver looks like. So many times my parents would be asking me when I'm doing biopsies for liver, do I need to put my child through this practice again? So how do we look at how we need to assess the fibrosis or how the liver is looking like in these diseases? So people have come up with different states, different ways of assessing how the liver is fibrosed and how things are going on in the liver without a biopsy. So what's being done is we have something known as a hepatic venous pressure gradient. I'll discuss about this in detail in my next slide. And there are some serological tests and serological marker panels, proteomic and glycomic patterns. And you have got a fibroscan where this is a machine which our liver takes transient elastography to assess the extracellular matrix of fibrosis in the liver. Basically sends a shear wave through the liver tissue, and the more the liver is fibrosed, the faster the shear wave goes. And before I go ahead, since the latest guidelines from NASPGHAN, the North American Society of Pediatric Gastroenterology Hepatology Nutrition, state that competence in liver biopsies is not required for a pediatric GI fellow, because most of the liver biopsies in institutes are performed by interventional radiologists, considering that the complications are less and they have post-liver biopsy ultrasound done along with the doctor to see if there is any bleeding going on. Now, coming to hepatic venous pressure gradient. So this is a way by which we can assess if there is fibrosis going on in the liver. How this functions basically is that you have a wedge hepatic venous pressure, which is measured by wedging a bulb catheter tip into one of the sinusoids. And after you, along with that, for comparison, there is the free hepatic venous pressure, which is measured. The difference between the two is the wedge hepatic venous pressure, which is basically the difference between the pressure in your portal system and the intra-abdominal IVC values. And if the wedge hepatic venous pressure is more than 5, it's suggestive of portal hypertension, more than 10 is suggestive of fibrosis in the liver, and more than 12 would guide you towards an impending venous bleed. However, this is not routinely much used in practice, being an invasive procedure. The next step would be the serological testing panels by which you can assess the amount of fibrosis going on in the liver, by which people have used hyaluronic acid, TGF-beta, and also collagen levels in the blood to check for the various proportions of collagen 1 with collagen 2 to see the amount of fibrosis going on. And some of this were not found to be effective, so the next step they try to see ratios, proportions, they develop various algorithms and mathematical formulas too. However, in the early fibrosis, none of these have been found to be effectively correlating with the liver biopsy picture. That's the early fibrosis picture. And the point to be put forth is that these in itself show if there is fibrogenesis or fibrolysis, which is an active process. Whereas rather than if there is actual fibrosis in the liver, these don't show it up. Proteomics is the study of proteins in your blood, the pattern of proteins, and glycomics is the study of the pattern of the sugar in your blood. So the ratio of the pattern of the proteins ratio and the ratio of the pattern of sugars. So this has been still an area of research, and they say this might reflect into the stages of fibrosis in which your liver is going on. It's being put forth as one of the further ways of assessment of liver fibrosis. So before I speak about the next topic, this is a fibroscan machine. This is a simple non-invasive procedure. It looks basically like an ultrasound machine. And what you see up there is a small probe. It gives you a small shear wave which passes through your liver tissue here. And depending on the amount of fibrosis in your liver, it reflects back. So what I can put it forth is that it's like a trampoline. So if your trampoline is tight and hard, you jump higher. If the trampoline is slower, and you don't jump as fast. So that's the mechanism on which it works. And going for fibroscan, what it is, it's a one-dimensional transient elastography. It measures the elastic shear rate. The good thing about this is that it has it directly measures what's going on in your liver, rather than just taking a small bit which you've seen in a liver biopsy. The standard depth through which it goes and the amount of liver tissue which it assesses is more than what you would do during a normal liver biopsy. The volume is around 100 times in a standard biopsy specimen. Doesn't have any complications. The only side effects being that it would not be useful when you have obvious ascites in severe liver disease patients, and this would not be useful when you have extremely obese patients or the intercostal spaces are a little smaller and you won't be able to go through it. And put forth that this won't be able to help you in diagnosis. This just would be help you to see if how progressive fibrosis is progressing in patients. Right? So what are the modern liver biopsy techniques? There's the percutaneous biopsies, you have transvenous biopsies, you have laparoscopic liver biopsies, and open surgical biopsies. So there are four: percutaneous, transvenous, laparoscopic, and open surgical ones. So percutaneous liver biopsy is basically under ultrasound image guided. You have a look at the lesion, go to it and target it. Simple. The other ways of going at it would be either an intercostal approach or a subcostal approach, and you have two types of needles: the true cut needle, which is severe, or the aspiration needle. Yeah. So the other point I would like to put forth is that blind biopsies without ultrasound guidance are considered obsolete. Nobody does them anymore because there are safer alternatives available. Most of the liver biopsies are performed by an IR, interventional radiologist. Use different types of needles: true cut, aspiration, spring needles. It's either ultrasound guided or CT guided. And as I was speaking earlier, you have an intrahepatic phase and an extrahepatic phase. So the intrahepatic phase is usually when you go through the muscles of your abdominal wall. Wait for the patient to hold his breath, puncture the liver, but the puncture of the liver is the intrahepatic phase, and you're out. And you can selectively, under image guidance, target liver lesions which are in your liver. Coming to transjugular venous biopsies. So usually the approach is through your IJV. You come down here, go through your cardiac cavity, to your heart, SVC, IVC, right hepatic vein. And once you're into the liver, you have a venogram done to show if it's in place. And after that, that's when you take a small bit of biopsy in here. You could have a transfemoral approach to this too. So it's speaking about transjugular liver biopsy, it's an IR technique. The indications would be this is done in more sicker patients who are not suitable for percutaneous liver biopsies. That would be patients who have coagulopathies, who have ascites, reduced platelets, not the ideal candidates for, not the OPD patients we will see for a liver biopsy. The other indications would be shrunken liver and malformations. I spoke to you about the techniques, the ones being through your interjugular veins, through vena cava, inferior vena cava, and right hepatic vein. The success rate is approximately 96 to 98% in various studies. The complications are the usual access site complications in terms of hematoma at your IJV or your femoral vein. You could have cardiac complications, so whenever you're doing this, you should have antiarrhythmic medications, the crash cart study. You know, the risk of developing arrhythmia during this procedure is around 1 to 2%, and you can have puncture of the liver if the catheter is in. You can have perforation of the liver if the catheter is in place properly. And the complications in recent studies have been shown to be around 7.1% with a mortality of 0.1%. This is equivalent to what is seen in patients with a percutaneous liver biopsy. But what we need to keep in mind is that the patients who undergo this procedure will usually be the sicker ones who undergo this procedure. So they are not at a comparable patient type to compare between the two.
Are those data from adults or for children?
So this is data from adults and pediatrics.
Both.
Both. So laparoscopic liver biopsies. So usually laparoscopic liver this is one of the procedures which is done as a side procedure whenever you're undergoing a laparoscopy. It isn't per se done for a liver biopsy. Usually when surgeons go in for some other procedure like having a look at your bowel, or if you're going in for an appendicitis, they take a snip of the tissue. But the good thing about this is that you have an adequate sample size, and you also need to get a look at the liver as to how it looks, how the jungle tissue, the surface looks like. Now, what surgical MICH biopsies? These are small bits of subcapsular liver tissue which are taken during a procedure like when a patient is going in for definitive biliary atresia, he's going in for enterostomy, and you need a small you take a small bit of liver tissue, a subcapsular wedge. The good thing about this is that it gives you a bigger piece. The disadvantage being that you have a focal tissue. In patchy diseases, you will not be able to pick up the pathology with this.
Is the laparoscopic one, is it like the wedge one, like is a chunk of that?
Yeah. They have specific needles which can aspirate core tissue during laparoscopy.
Because I guess there's some concern about the wedge on the side.
Yes, the problem being that in laparoscopic liver biopsies, you can even bore in and take a complete piece, whereas in surgical biopsies, you snip a bit of subcapsular liver, you don't go in much deep. So that's the issue about a wedge biopsy.
So you would prefer the
laparoscopic liver biopsy. So what's an adequate liver biopsy sample? Because sometimes you send biopsy samples to the pathologist, don't get back the report, they say it's not adequate. So the first thing is it usually represents 1 to 50,000 size of a liver biopsy, of the liver size, sorry. It should be either 1 to 4 centimeters, approximately 1 millimeter in diameter. What the pathologist should be able to see is approximately 10 to 11 portal tracts. With the minimum, some people are happy with 6, or it depends on how good a pathologist is, but for him to make a definitive diagnosis in terms of what's going on in the liver, we need at least 6 portal tracts to be seen in the liver biopsy sample. Now, what are the indications for a liver biopsy? Why would you do a liver biopsy? Abnormal liver tests, immunity cholestasis, and clarified hepatomegaly metabolic disorders for diagnosis and staging of chronic hepatitis. Some routine centers do for liver transplant patients at the end of 2 weeks post liver transplant. They want to look at how the liver is going, what's going on in the liver. That's when you have liver biopsies. The other way around for liver transplants is to know if they are in acute rejection prior to starting treatment. We're going to go liver biopsies. For diagnosis of GVHD liver, it's again a liver biopsy, and for focal liver lesions and malignancies is what you would again go for a liver biopsy. So what are the contraindications for a percutaneous liver biopsy? As again, the usual impaired hemostasis, there's ascites, any vascular malformations in the liver, like hemangiomas, any echinococcal cysts in the liver. The problem with the echinococcal cysts is that once you puncture them, they can start an anaphylactic reaction and the patient can be in shock. And if you don't have transplant samples. So it's usually a safe procedure. The complications with this are usually as minor in nature. 80 to 85% of the patients could have pain, minor bleeding, which I would define as a small subcapsular hematoma, which does not cause any circulatory problems in the patient, does not have required transfusion. This would be considered a minor bleeding. Up to 15 to 25% of patients in various series show transient hypertension for up to 2 hours post-biopsy due to vasovagal symptoms. The major complications are usually said to be severe bleeding, which requires either injection of thrombin or ligation or surgical exploration or requires transfusion. Different studies have defined severe bleeding with different criteria. And it's said to be 1 in 2,000. This is again adult and pediatric data. And the mortality is said to be 1 in 10,000. So what are the other complications? You could have perforation of other organs, lungs, puncture of other organs, peritonitis, hemophilia, neuralgia. Various case reports have been depending on where your needle has gone. What's good to know is that most of the complications are picked up during the first 4 to 6 hours. And that's the previous protocols asked for overnight observation over 24 hours for liver biopsies. But now the adult observation times in American hospitals or the US hospitals are less than 6 hours for patients who are undergoing liver biopsy on an outpatient basis. So what are the complications of the manganese needle in itself? The needle which is used for a biopsy is around 1 in 1,000, which are the high-risk patients whom I would want to observe overnight with a liver biopsy. They would be the ones who are having malignancies, the ones with cirrhosis, the ones who have undergone bone marrow transplant. So these patients, I would try to get transjugular biopsy for these people because the complications are less. If this patient is having cirrhosis, it's difficult for the IR guy to focus onto the liver because the liver will be shrunken and small. So it's easier for the guy who's doing a TJ to get a liver biopsy sample. The pediatric complication rate in various studies has been shown between 0 to 6.83%, and the major complications have been said to be between 2.4 to 4.5%. So before I would like to discuss a few biopsies, what I would see in a few liver diseases and how liver biopsies helps me getting a differential diagnosis for each of these conditions. Like in urinary cholestasis, autoimmune hepatitis, sclerosing cholangitis, metabolic liver diseases, and in NAFLD. So let's go back to what we remember about from physiology and anatomy about what we read about the liver. So as you all remember, the blood flow is always from the portal vein branch towards the liver vein tributary, and the bile flows in the reverse direction. What we'll see in a liver histology would be the central vein here and the sinusites by the side there. So this is what a normal liver biopsy would look like. The portal triad at the periphery of the lobule with a central vein up there. These are the sinusites in here. The cords of hepatocytes radiating from the central vein towards the portal triad with no fibrosis. Sorry, I have not put up a triad. So urinary cholestasis, how would this help you? So the emergency in a urinary cholestasis is always biliary atresia, which constitutes around 30% of the patients. If there are patients with biliary atresia, these are the ones we are rushing to get in to get a Kasai's portal enterostomy done. Because outcomes in terms of a Kasai's portal enterostomy are more favorable if the patient undergoes a portal enterostomy prior to 60 days of life. Hence, the rush for getting a liver biopsy, there's always a rush for getting these patients diagnosed with biliary atresia. The other conditions for urinary cholestasis would be infections, bacterial protozoal, there will be metabolic and genetic diseases, allergens, defects, glycogen storage disorders, and alpha-1 antitrypsin. I'll be discussing about the histological features of what you will see in each. Toxic allergen and others. So, as I spoke to you about, we are in a rush to look at biliary atresia. The liver biopsy is 90% sensitive and experience hands to pick up biliary atresia. Allergen syndrome would be classically having the other features and genetic JAK1 present along with other features like pulmonary features, cardiac features, and alpha-1 antitrypsin deficiency. You don't require a liver biopsy to diagnose this; it's more diagnosed on the variants. But when you do a liver biopsy, you would classically get diastase washout negative crystals and defects, and sometimes it can guide you towards the etiology of cholestasis in terms of having, if you see metabolic, if you see steatosis, you would think it more in terms of a liver storage disorder. So in biliary atresia, what would you see as the classical features? What you see here up there is a small bile plaque. You see ductal proliferation down there and fibrosis along with ductal reaction in that area down there. So there was a small study from Egypt where they studied around 81 patients with urinary cholestasis, out of which 53 were diagnosed with biliary atresia. So the most consistent features for biliary atresia, what they found was bile plaques, ductal proliferation, and intracellular bile paintings as the classical features which were seen in most of the patients are most sensitive to diagnose biliary atresia. Allergen syndrome. So this is also known as paucity of intrahepatic bile ducts. What you will see is absent bile ducts in approximately 50% of the portal tracts. This is associated with many diseases, and allergens is suspected if you have other features or allergen syndrome, and genetics testing could show if it is JAK1 positive. Alpha-1 antitrypsin deficiency is an inherited metabolic disorder. Hepatocytes are able to produce alpha-1 but not able to excrete it. Basic defect is that the protein is structured in such a way that it accumulates in the liver and causes the liver disease. What you would see classically is ES positive, DIS positive granules, which are seen down here. And usually the biopsies are normal, except for vein rosettes and bile plugs, which could be seen. Sorry. The PI phenotyping and genotyping would help you in terms of what type of disease it is. So the genotype PIZZ is associated with a worse outcome. PFIX. What is PFIX? PFIX is progressive familial intrahepatic cholestasis. This is an umbrella term which is used for progressive cholestasis. The basic defect is that the hepatocyte is not able to secrete the bile from hepatocytes into the bile duct. They are autosomal recessive and they present with intrahepatic cholestasis in either infancy or childhood. It is of three types, type 1, 2, and 3. Discussing about all three next. So PFIC type 1, the defect is in the PFIC1 gene, and it's in the protein which encodes for this is phospholipase, and the bile transport is affected. So the defect is at two places. It's either in your liver, it's in your liver and also in your ileum. So that's the reason for this is that phospholipase helps in excretion and reabsorption of bile salts. So these patients also present with chronic diarrhea because the reabsorption of bile salts is affected in the ileum, and which leads to result in diarrhea. The biopsies are usually normal, but you have vague rosettes and bile plugs. So how would you diagnose this? The way for diagnosing this is that it comes through EM findings, that's electron microscopy findings. So what you see here is the coarse granular bile, which would be seen classically to PFIC1 down there. And this, what you see here in the lower EM sample, this is from a patient with biliary atresia who has dilated canaliculi, but you have a normal bile in there. PFIC2. So the type 2 is a deficiency in BSEP, which is bile salt excluding protein. Immunohistochemistry here helps you in the diagnosis. So when you do immunohistochemistry, that is antibodies are made against BSEP, which along with which the liver sample is stained. So what you see up there in A is a patient with normal liver, where BSEP would be staining in those. So what you see those brownish lines in here, that's where you'll see the lining of the ducts with, sorry, so what you see these brownish lines here is where BSEP is present, and that's where the stain goes and sticks in. And you see a normal pattern of canaliculi with BSEP present. Now when you see a patient, another patient who has PFIC2, you don't see the staining, the normal brownish pattern what you would see in a patient with PFIC. And you can see the disordered structure of the hepatocytes and the canaliculi are seen here. Similar to what you would see in PFIC3, where the defect is in MBR3, and up there you see a normal liver which is staining for MBR3. The basic defect in PFIC3 is that it encodes for ABCD4, which encodes for MBR3, which is associated with the transport of phosphatidylcholine into the bile. And there's a phosphatidylcholine deficiency in the bile. This causes you to have inflammation of your gut epithelium, and this causes an elevated GGT. So how would you differentiate between the three PFICs is that for say type 1, the EM findings would make you to see granular bile. Type 2, you will and type 3 is where the immunohistochemistry for each one of the two, that's either MDR3 and BSEP would help you to diagnosis. In sclerosing cholangitis. So So the usual diagnosis for sclerosing cholangitis is usually either by an MRCP or a DRCP, where it is around 86% sensitive and 94% specific. This is again adult data. You have classical findings of bleeding being present in the biliary. What would you see in the biopsy findings? And so you see onion skin fibrosis. Since it's a patchy focal disease, so sometimes the biopsies might not show up positive. You'd see portal inflammation, but no interface hepatitis. Why would you want to do a biopsy in these patients? Because you can pick it up with 86 and 94% sensitivity and specificity in terms of MRCP. The reason for doing this in pediatrics is that you have something known as an overlap syndrome, where you have autoimmune hepatitis overlapping with sclerosing cholangitis, what we call as an ASC, autoimmune sclerosing cholangitis. So what you would see in ASC in pediatrics is that this is steroid responsive. The parenchymal changes in the liver, they respond to steroid therapy. Whereas if you have classical PSC, they won't respond to steroid therapy. Now, coming to glycogen storage disorders, classically, these are not diagnosed on a liver biopsy. It's usually a metabolic disorder has multi-system involvement to see storage of glycogen in the liver. Liver biopsy is said to be the first step prior to enzyme analysis. And what you will see is classically EAS positive granules, which show normal washed out cells post diastase, which proves that this glycogen is there. And MAFRD. This is the most common pediatric liver disease now. The reason is increasing obesity in kids. Shows up with high deposition in the liver. MAFRD is usually benign, but NASH, which is worrisome, it leads to liver inflammation and leads to cirrhosis further on as it progresses and can lead to HCC. It's usually diagnosed on a biopsy. So what you see here is the classical findings of NASH, which shows you ballooning of hepatocytes here, and you see the Mallory-based bodies there inside. So the biopsies, you would have an adult subtype or a pediatric subtype. How you differentiate between the two is that if you have centrilobular fibrosis, it's usually the adult subtype, and when you have fibrosis around the portal tract, that's when it's the pediatric subtype. So coming into my current research, what I'm working on, just the preliminary data which I'm presenting on. So we did a small study where we looked at the clinical characteristics and complications of pediatric liver biopsy. And it was from a single center, that's what we looked at. We have a tertiary level children's hospital in Bangalore. We serve patients with problems of BC and UCA. We do approximately 35 to 45 liver biopsies per year, depends on the patient load. And our institutional protocol, which was put up around 10 to 12 years back, as per the NASCAN guidelines, that it constituted overnight observation after liver biopsies with labs being done, repeat hemoglobin being done after 4 to 6 hours of liver biopsy. You're wondering about the benefits of a shorter observation time post liver biopsy, because one bed a day is around $1,500, and it would be helpful considering the constraint of beds to reduce the observation time for outpatient liver biopsies. So the aims were to study the clinical characteristics of the liver biopsy patients and to see the nature and the timing of complications post-biopsy. What we did was a retrospective chart review from 2006 to 2012. Prior to this, the records weren't computerized, so we didn't have access to them. It's always easier to have computerized records and have an access to them. And the data collected was basically demographics, the biopsy type, the service ordering the data, indications, complications, along with timings. So what we found was that we had 188 patients who underwent 223 biopsies. The reason being that many of the patients undergo repeat biopsies to see for the staging and the progress of disease. What we found, we took 188 as a denominator, and what we found that 110 males and 78 females. The median age was around 9.2 years, with the range being 1 month old to an 18-year-old kid. Indications, the most common indications what we found were elevated liver enzymes, which was approximately 45% of the patients, and around 81 biopsies. The other most common reason was conjugated hyperbilirubinemia, which was seen in 30 biopsies, that's around 70% of the patients. So what we found was that 163 were percutaneous biopsies, 16 were transjugular, and 44 were wedge biopsies. We excluded wedge biopsies from the study, considering that there were a different subset of patients who had these biopsies taken during a surgical procedure. So, out of these 102 patients, so what we had was 163 plus 16, which was around 179 patients. 102 were outpatients, 75 inpatients, and 2 from the PICU. Post-biopsy, the monitoring, the median stay for outpatient liver biopsies was around 20 hours in the hospital. So what we found in terms of complications, we found that analgesia was required in approximately 106 cases, which constitutes around 60%. Opiate analgesics were seen in were required in around 28 cases, which is around 21%. So this is opiate analgesics with prior use of NSAIDs. The other complications what we found was 6 of the patients had a hematoma at the biopsy site. 1 of the 6 patients had a capsular hematoma, which we considered as a significant complication, and this required the post-liver biopsy. We have a protocol of repeating the ultrasound post-liver biopsy after an hour. The repeat ultrasound did show that and the Doppler being done at that time showed that the patient was still losing blood, and hence the IR grade where I had to inject some chloride to stop the bleeding.
By opiate, are you including codeine or just more powerful narcotics?
Right.
Codeine is part of opiate?
Yeah. Codeine, morphine, and 2 of the patients had received fentanyl. I'm sorry, I have not done the complete analysis, but there were a few patients, I remember from the back of my head, there's around 2 patients who had received fentanyl. All the bleeds were detected in post-biopsy ultrasound. Now, we also have a routine biopsy, routine post-biopsy CBC at 6 hours. 10 of the patients had hemoglobin drop more than 20 grams per liter. However, when we had monitored these patients, none of them had any hemodynamic instability and none of them required any transfusion. Most important thing which looks good is that there was no mortality. And the median time to recognition of complications was around 1.6 hours. However, the range extends from half an hour to 23 hours. The reason going up to 23 hours is that many of the patients had pain presenting at 23 hours. 85% of the complications were detected within 6 hours. 89% of the complications were detected within 8 hours. And only 11% of the complications were detected after 8 hours. However, all of these were the minor complications. Now, the conclusions what we derived from this is that this was a single center study. Liver biopsy is a safe procedure, no rate of complications. Majority of the complications were minor, and most were recognized within 8 hours. The guidelines for pediatric patients, that's the outpatients, post-liver biopsy, they should likely reflect the time of complications. So whether the overnight observation, which is from the guidelines, which was around 12 or 15 years ago, does it still hold good? Was the question for both. And in summary of my talk would be that liver biopsy is still the gold standard. We do require it for diagnosis of patients. We do require a proper team in terms of an experienced pathologist who basically sees liver diseases in diagnosis of and staging of liver disease. Liver biopsy is safe, complications are rare. They usually occur in the first few hours post-biopsy. And maybe you could consider economic benefits of shortening observation post-biopsy. Thank you.
great. Well, it's been a great overview of the value of obtaining liver tissue, how to get it, and maybe how safe it is for the patients who need to undergo it. So, any questions?
Sure. How often do you find yourself doing liver biopsies in patients with fatty liver disease?
So usually, if the enzymes are elevated more than 3 times, and the institution has a specific protocol in terms of NAPRID, that is when you have the ultrasound test show classical changes. So we do get reference for that, but I mean, we have 2 hepatologists and everyone has a different approach. Some are more aggressive, they want to go in with a straight biopsy to see what's going on. Others would like to have a wait and watch approach in terms of trying the management, asking in terms of getting the weight loss, and then go further on if the enzymes don't stabilize and they would like to go into a biopsy.
Thanks very much. It's a wonderful example of a quality improvement project. Following up on Dr. Tabak's question, we have a large population of children with type 2 diabetes who have First Nation ancestry, most of the children. And about 20% of them have persistent elevated liver enzymes with an ALT of greater than 100. Many of them are morbidly obese, not all, some of them. And in our experience over a long period of time, weight loss doesn't necessarily correlate with changes in their liver enzymes. So I guess 2 questions. Number 1, what about the very large abdominal wall, which affects sometimes decision for kidney biopsy, no question.
Exactly.
And I wondered whether, rather than talk about the other pathology, in your experience, in terms of where you go with this, where do you fit on the continuum of aggressive versus let's wait and see in terms of liver biopsy? And second question, because we have not been biopsying very many of them over the last 20 years or so, we've watched liver enzymes and many of them normalize over time, but not necessarily in relation to changes in their body weight. And I wonder if you have any comment.
So my personal approach would be I have an aggressive approach.
You do have one?
I mean, I would want to go in for a biopsy to see what's going on in the liver, and then decide for the treatment. The other thing being that we don't have specific therapies for NAFLD at present in terms of liver diseases. Then if you do that and diagnose it, it's basically weight management of the glycemic symptoms. I know there are things being studied in terms of, I did speak to somebody yesterday and there are some new drugs which are being tried. But I think I would go in aggressively for a liver biopsy to know what's going on, at least to differentiate whether it's MASH or it's something else. That would help you as from the endocrine part to differentiate on how to get, whether you want to be aggressive with go ahead in terms of weight loss, exercise, and other glycemic control.
Would you do that percutaneously or transjugular?
I would try to go in for a transjugular approach for those patients, considering if the patients are obese, it's difficult to, the complications are more.
You're making yourself feel very
I just put in lines like that. I've never heard of that. Well, I've never heard of it either. It's like,
Oh, it's done, you're not wearing it, it doesn't know that, he comes over to kids.
I would try to go in, considering these patients have a morbidly obese, I would like to go in for a transjugular biopsy. It would be difficult to get sedation for these patients. IR guys would be really...
that might be motivation for weight loss and exercise.
It's only that simple.
Okay, that was like that.
Any other questions? Or yes, Dr. Wicklow, you have an interest in
You know, we talked yesterday for an hour, so I'm not going to ask any questions I already asked him yesterday. He's going to fibrogram all of our kids, and then I'll see if I need to do spectroscopy on them anymore. We have that plan. My question was actually about education, mostly because you said that you don't need to learn this. It sounds like it's a skill you are learning in BC. And so my question really is whether or not this is something that GI trainees are going to get. Because I actually think we had a paucity of the ability to do this for a while because nobody in the pediatric world anyway was doing it. So I don't know that all of our biliary atresia when I was a resident here got biopsied. I don't I don't think so, because we didn't have an interventional radiologist that did.
Diagnose them on the HIDA scan, that's one of my questions.
Yeah,
We
so
do
I-
liver biopsy for biliary atresia, we have the HIDA scan.
If you have, the reason being that in a HIDA scan, you won't be, if the liver isn't functioning well, you won't excrete and pick it up. So at that time, you do need a classical liver biopsy to diagnose it.
The overall liver is not functioning. And if you don't get excretion, you still don't know if it's just the liver not functioning or if it's true biliary atresia.
Exactly.
So you're being trained to do this, as a fellow in GI?
No, yeah,
You are not.
but it's, the onus is on us. If it's something which you want to learn, then the program does provide you an opportunity to have a slot with the interventional radiologist. They put you in a slot for 1 day, where usually we have an adult guy coming from St. Paul's who comes in, he gets biopsies done. We have all of the biopsies slotted for 1 day, 3 to 4 hours, and it depends on his workload. And he does those biopsies and goes off. This is how we function. But the program does offer you an opportunity to go and work with him on those days to pick up the skill. So,
And it's ironic, Dr. Almenteri just got called away for a biliary atresia consult. We had one the other day. Well, we don't know if it is, I guess it's probably.
But I would say most of our biliary atresia did not get a liver biopsy.
I think they are now. The one the other day did.
Well, I would,
Yeah, I don't know.
well, after that, but.
So, I mean,
But they follow up with, 24, 48, 72 hours, see if you get any excretion.
As long as someone's checking their cortisol.
Usually you can,
24, 48 hours.
figure it out.
The class, even if you are in doubt, what you would do is get an intraoperative angiogram. That's when you
Yes.
open up
I would agree, yeah.
and you inject dye and check if it goes up back and forth. 2 ways, that's when you check up. And there are different types, type 1 and type 2 of biliary atresia. So depending on those, the anatomy will be quite different, whether it's hepatic or extrahepatic.
Hi.
Potential of learning and here and then there.
From the adult perspective, as a hepatologist, I was very surprised at the low number of biopsies that you perform. And when you compare that to the adults, I think I ordered more biopsies this year, or maybe in 6 months, than what you have per year there. And we've had major complications. I mean, they're rare, but there are complications. So can you conclude that it's safe with the number of patients that you have?
I mean, that's a good point to put forth. Our sample size is pretty small. We are a one-center study. But when I did look at the data, and when I did see the data from other institutes, I mean, what I would put forth is that it looks like a safe procedure unless and until you don't have some red flags in you. Like I spoke about the high-risk patients, those who have malignancies with cirrhotic livers, and you altered hemostatic parameters. But in terms of my short study, as you said, I won't be able to comment forth that it's a relatively safe procedure. Just depending on my data, I won't be put forth. If I do look at the generalized data over 4 or 5 institutes, and I think it's a relatively safe procedure.
You and then Doctor?
My question was the role of molecular diagnosis and the timing of liver biopsies. If a case isn't urgent, so to speak, like for Alagille's or the PFIX or some of the other ones, like storage, I don't remember ever doing a liver biopsy. Recently, we would wait for the molecular panel to come back for PFIX, for the GSV panel. Do you do the DNA first, or do you actually go to liver biopsy first for Alagille's and the metabolic cases?
And you're talking to a geneticist, just so you know.
So for the liver biopsy, you're speaking about, so it depends on personal preference. If it comes to us as community cholestasis, we get both things simultaneously done in terms of the JAK1 gene being sent for an Alagille syndrome, along with the liver biopsy. Because sometimes if it's an atypical Alagille and you're not able to pick up the symptoms early on, right? If you don't have the classical symptoms of Alagille syndrome, that's when a liver biopsy would help you. But for confirmation of diagnosis, it's always genetic study.
We currently don't do routine ultrasound post-liver biopsy. people who do CBC. I'm just wondering what's the added value of doing a routine ultrasound on all your cases as opposed to just doing it when you suspect a complication?
That's a good question.
Let me ask another question related. Is it point of care ultrasound, like you do the ultrasound yourself or the radiologist?
So usually the patient is observed for 1 hour post-biopsy by the IR guys in the radiology room. So before the patient is sent up to the wards, they have an ultrasound done to see if there's an active ooze going on or if there's a bit of that. So it's the point of care. But I'm sorry, I wouldn't be able to comment on, but I think it's basically the comfort of the radiologist is that he wants to see if there is no active ooze, is not increasing in size. That's the reason for him to do the first biopsy or to see if there's some ooze, there's some blood in the abdominal cavity which has happened. So maybe if there are some major complications which can be picked up prior to the 4 or 6 hours when you do the blood works. That's what's the rationale behind ultrasound, to pick up the complications earlier than the 4 to 6 hour window. Wait for the patient to become hemodynamically unstable and then pick it up. That's a rational approach.
Okay, well, I want to thank you for engaging.